Okay, I think you guys give me the feedback that you like your videos short, so I'm going to try and make them anywhere from 5 to 10 minutes and try and make sense of where I stop off. So this concept, we're going to talk a little bit about reflection and refraction. We already talked about the absorption of the tissues in the slide prior to this. Um, oops, sorry. This one right here where we talked about the absorption coefficient of tissues. So now we're going to talk a little bit more about the reflection and the refraction, which comes off of that sound head. So the sound head comes in here onto that tissue. Some of it goes and transmits down. When we talked about that, anywhere from 1 to 5 centimeters, you get a little bit of refraction going off here. So it goes off in a little bit of an angle, and then a little bit of it bounces off and comes back out and just goes back into the air. So this is the tissue, and so this is talking about how much of that energy actually gets into the tissue directly, goes off a little bit around that area, and then how much of it just goes back into the air. Okay, so that's what we call reflection and refraction. So we talk about this has this alternating electrical current, and we have what we call the piezoelectric crystal. Different sound heads are made of different types of crystals. They use a fairly inexpensive one now. The different materials that they use, and so it used to be you had to be really, really careful to not let that sound head just be open in the air without any contact with the machine on. You could break that sound head and then it would be inaccurate and you'd be more susceptible to burns on your patients. They have improve that quite a bit. You still want to be careful and have good contact, but you're not going to be as concerned about it destroying that sound head, which is kind of, and they have a little beep system if you aren't on contact to kind of let you know where you're at. So basically what happens with that is you get this expansion and this contraction at the same frequency, and you have that alternating compression rarefaction we talked about that creates that wave. So this is just demonstrating how that's going to look when you're using a 1 megahertz versus a 3 megahertz. So with the 1 megahertz, I always like to compare these for you so you know which is deeper and which is more superficial. I think it was when I was in PT school, the example they used was, if you have one relationship, you're a little bit more serious, you're a little bit more deep, and so then you realize that that 1 megahertz is going deeper into the tissue. Whereas 3 megahertz, you may have 3 people you like, you're not quite sure which one, so you're a little bit more superficial at this point. And so it's the one that's going to go more that 1 to 2 centimeters into the tissue, whereas that 1 megahertz is going to go about 5 centimeters into, or 2 inches about. Okay, so here's that terminology talking about the regions of high versus low molecular density. And so that's just showing you that sound wave in the areas that compress and the areas that rarefy. And the transducer is just the sound head itself that's emitting that energy. Attenuation, we talked about that. That's just basically how that sound head is, the sound waves are delivered into the tissue. Oh, go back. So as we go farther into the tissue, obviously the energy, that intensity decreases as we travel through the tissue. Okay, so it's going to be hotter here, and then it's going to kind of decrease as we go deeper in. So this is your effective radiating area. So you have this transducer head that we talked about on the ultrasound, and on the top of it is the face of it. So you always have this little outside area called the face, and then on the inside part is what we call the ERA, and that is the actual portion that produces the sound waves. So you're not getting any sound waves from this outer layer, only from this inner layer here. And we'll talk about when you go to do ultrasound on someone, we have different size sound heads. Really tiny ones like 2 centimeters squared, a 5 centimeter squared, and then the bigger one is the 10 centimeter squared. So depending on what body part you're doing, you're going to want to decide what sound head you want, because basically you're going to use an ERA and an area that's twice the size of this ERA. So you can see if I use twice the size of this, it's going to cover an area about this big. If I have the smaller sound head, I'm going to be doing a much smaller area. And so those are kind of how you use your clinical judgment to decide which one you would like to use. So along with that comes the BNR, which is that beam non-uniformity ratio. And you can see it kind of looks like your hand, little fingers. And so basically you can see that the heat doesn't distribute evenly. It kind of has little areas of peaks and balances. And so when the FDA calibrates these, it has to be less than a 6-to-1 ratio so that that patient doesn't have an uneven burning and cause them to burn because you have too many spikes that are too different in size and shape. And they say that's the purpose of moving the sound head, so that you are distributing that heat a little bit more evenly. There is some research out there now that's saying that maybe that is not necessarily true. So those of you who are going to do the ultrasound for your research, you can look that up for us and follow up and tell us what you think about that. I'm going to keep going on this one a little bit just because of the terminology. Your duty cycle, so that's basically telling us whether it's a continuous cycle or it's a pulsed cycle. So generally with pulse, that's going to be the non-thermal. So here we have a 20% duty cycle, and that's where it's on for 2 milliseconds and it's off for 8 milliseconds. So you're kind of using the 10 milliseconds as your parameters, and 20% of that would be 2, and then it's off again for 8. So it's on for 2, off for 8, on for 2, off for 8. And then if we're going to do a 50% duty cycle, that means you're going to get about 50% non-thermal and 50% of a thermal effect. So it's going to be on for 5 milliseconds and off for 5 milliseconds. So you get the thermal, non-thermal, thermal, non-thermal. So you can see with the 20%, you're not going to get much thermal. This would be an ideal pulse rate to be using for somebody in that acute inflammatory phase where you want to get those mechanical effects of healing without hindering the healing process. And this would be more when you're wanting to get more into that proliferation phase where you're getting a little bit of both. You still have a little bit of inflammation going on, so having a little bit of non-thermal is good, but you're ready to start getting a little bit of vasodilation going on in there. Okay. Cavitation is that formation of gas-filled bubbles that expand and compress due to ultrasound-induced pressure changes in the tissue fluids. And then the microstreaming is that unidirectional movement of fluids along boundaries of cell membranes resulting from mechanical pressure. So these two are what create that non-thermal effect of ultrasound, is what the theory believes. Okay, and so this is just kind of showing that when you have stable cavitation, what happens here and how it rings around. And if it's unstable, you get those free radicals and it can implode. And that's the other reason why you want that sound head to stay intact. So here we're just showing the pulsed ultrasound. You have the intensity, and it's going to be measured in watts per centimeter squared. And so you're going to want to be careful of this when you're setting your parameters on the ultrasound machine, and we'll demo that on Monday, that you're not just on the watts, that you do the watts per centimeter squared, and that's how you want to document it in your SOAP note as well. And then here we have time is in milliseconds. Okay. So this is that person who's the 20% cycle where it's 2 seconds on, 8 seconds off, or milliseconds off. Here's the theory behind that pulsed ultrasound. It alters that membrane permeability. So that's where we talked about that acoustic streaming and cavitation. You get these non-thermal effects of tissue healing, modified inflammation. And you can also use this as a way to put certain types of anti-inflammatory drugs through the tissue. We call that phonophoresis, and we'll talk about that in a little bit later, but this is, you do that with a pulsed setting. Other non-thermal effects, it can alter that cellular activity. We've already talked about this with diathermy a little bit, which is a key to healing. You get that normal cell function, increases the mast cell degeneration, you promote that macrophage response, the rate of the protein synthesis of the fibroblasts that change, and you get the increased histamine releases, which what you're wanting for tissue healing. Okay, so we're going to stop there, and we'll talk about continuous on the next video. Thanks.